Very good afternoon to one and all. In today's session, I'm going to discuss about mandibular fractures and its management. We are all aware that mandible is the strongest and the largest bone and the only movable bone of the facial skeleton. Mandible is the only movable bone, as I mentioned earlier. It maintains the airway, it allows us to eat, chew and swallow. Along with the function, it also plays an important role in aesthetics of the patient. Thus, it has both aesthetic and functional importance. Now, this slide shows, because of the most prominent nature of the mandible is more prone to fracture. Around 30 to 60% of the maxillofacial fractures are mandibular fractures. This slide shows you the percentage, that is the most favorable side of fracture of the mandible, wherein the angle constitutes 25%, the body around 29%, condylar region around 26%, symphysis fracture 17%, ramus 4% and coronoid process around 1%. Now these differences, you might be wondering why only these specific areas are only fractured, why not the other? Now this is because of the inherent area of weaknesses that are present in the mandible. As you can see in the slide and at the same time as you can see here, the most important anatomical difference is the dentoalveolar structure and the base of the mandible. The junction of this dentoalveolar bone and the base of the mandible is weak, resulting in fracture. At the same time, the mandible, both of the sides come together and fuses in the midline. Now this is also a potential weak site of fracture. Parasymphysis region is also weakened up because of the incisive fossa and the mental foramen, resulting in fracture. The angle of the mandible. As the mandible, you see from anterior to posterior, the width and the bone keep on increasing and decreasing. As the ramices form, the bone become more thin. There is change in the trajectories, resulting in fracture of this angle region, making this area more prone to fracture. Moreover, angle region, third molar are impacted in this region, making angle more susceptible for fracture. At the same time, the neck of the condyle is very slender, now due to which it is more prone to fracture. Now the curvature of the mandible is such that when a force is applied, the cortical plate will fracture in a different way and a lingual plate will fracture in a different way. Before we start with the clinical feature and the treatment, we should have some idea regarding the biomechanics of mandibular fracture. We are all aware that mandible is similar to an arch and it distributes its force of impact throughout its length. But unlike arch, mandible is not a smooth curve of uniform bone. Rather, it has irregularities. It has depressions, fossas, foramens, thick and thin ridges. Okay, because of these differences. When force is directed in the parasymphysis and body region, compression occurs on the buccal aspect, whereas tension on the lingual aspect. This results in fracture at the site of application of force and contralateral condylar fracture. And if greater force is applied, it could either result in ipsilateral condylar fracture. When force is directed along the symphysis region, tension develops on the lateral aspect of the condyle and on the lingual aspect of the symphysis region, which result in bilateral condylar fracture and symphysis fracture. But variation do exist, and these variations depend upon the magnitude and direction of the impact, the shape of the object delivering the impact, the presence and absence of dentition, the position of the mandible, and influence of the associated soft tissues. Now, Lindahl divided trauma causing condylar injury into three main groups. One is the kinetic energy imparted by a moving object to a static individual. That is, now trauma sustained in case of wrist during sports activities like boxing and interpersonal violence. When a moving object like wrist is forced towards the stationary mandible, that is jaw, will result in parasymphysis fracture at the site of contact and contralateral condylar fracture. Now, when the kinetic energy derived from the movement of the individual and exerted on a static object, for example, when a person or the individual is moving and it hits on to a stationary object like floor, like in case of fit, the person's fall unprotected over the chin. In case of faint, if the persons fall down unprotected with the arms stretched, This is also termed as parade ground fracture, most commonly seen in soldiers during the time of parade. Now this results in symphysis fracture and bilateral condylar fracture. When kinetic energy, which is summation of force derived from both 1 and 2, that is, both the object is also moving and the person is also moving towards each other. The most common thing is road traffic accident. It results in bilateral parasymphysis fracture and condylar fracture along with other maxillofacial injuries. Now, muscles also have their influence in the displacement of mandibular fracture. Now, we all are aware that on the inner aspect of the mandible, the muscles that are attached are genohyoid, genoglossus, mylohyoid, anterior belly of digastric. They tend to try to pull the mandible in an inward direction, medially and downward. Alright, wherein you can say the masseter. The masseter, when the fracture is in anterior to the anterior border of the masseter, the anterior segment is moved down towards inferiorly by the downward pull of the muscle, whereas the posterior segment, that is the ramus wherein the masseter and temporalis is attached, that will move upwards. Okay, wherein in case of the condylar neck fracture, the lateral pterygoid muscle is inserted into the medial fossa of the condylar neck. So when fracture occurs, the condylar neck or head of the condyle will move medially and anteriorly. Thus, the muscle also plays a significant role in displacing the fractured segment. Let's move on to the classification of mandibular fracture. We begin with Kruger's general classification. Kruger has divided fractures into a number of things like simple or close fracture, wherein a linear fracture occurs in which there is no communication with either intraoral or extraoral compartment. It's just a single linear fracture. For example, coronoid fracture. There is no intraoral or extraoral communication. Compound or open fracture, wherein there is presence of an either extraoral scar or laceration or intraoral scar or laceration is compound fracture. Comminuted fracture is nothing but the fractured fragment is splintered into number of pieces, is comminuted fracture. Complex or complicated fracture is fracture of the bone associated with vital structures like fracture of the condylar head displaced into the middle cranial fossa, that in vital structures are hampered or affected. Impacted fractures, not very common in the mandible, it is more commonly seen in the maxilla wherein one fragment is driven into the other fragment. Then green stick fracture, seen in young children and young adult, wherein fracture of one cortical plate takes place but the other cortical plate is intact, resulting in green stick fracture. Pathological fracture occur in older age, wherein the calcium deposition decrease, the mandible become more atrophic, or in case of a pathologic lesion like cyst or benign tumors, making the mandible very thin and the inferior border very thin, resulting in pathologic fractures. Dinming and Natwig have also classified mandible fractures depending upon the site where the fracture takes place, like dentoalveolar fracture between the dentition and the bone, symphysis fracture in the midline, parasymphysis fracture, angle fracture, condylar fracture, and coronoid fracture. According to the direction of the force and the favorability of the treatment, Frears and Associate had classified fractures into the favorable and unfavorable type, based on whether or not the line of fracture was in such a direction to allow muscle distraction. Okay, so what is horizontally favorable and unfavorable? When you look at the mandible on the lateral aspect, okay, here the masseter is attached, which pull the mandible upwards, and here is the temporalis is attached to the coronoid process. When you see if the fracture line is moving from the alveolar process and moves downwards to the inferior border, there is unhindered movement of the ramus segment. The ramus segment can easily pull up. Okay, so this is unfavorable fracture. Where in the similar way, if you see here, if your fracture line move from the alveolus for downward and forward direction, here the posterior segment is getting hindered because anterior segment will occlude to the opposing teeth, and your posterior segment, there is mechanical obstruction here. So your posterior segment will not move upward. Thus, this is a favorable horizontal fracture. Then we move on to vertical favorable and unfavorable fracture. When you look at the mandible from the occlusal view like this, okay, and if your fracture line passes, if you can see here, if the fracture line is passing from the lingual cortical plate outward to the buccal cortical blade. Okay, so this posterior segment, here your mylohyoid muscles are attached. It could easily move inside, medially inside and downward, resulting in unfavorable fracture. But when the fractured segment passes from lingual cortical plate anteriorly to the buccal cortical plate, this segment is not able to move because lingually there is a ledge of bone that is stopping it mechanically. So this is vertical favorable fracture. Let's move on to the McLean's classification of condylar fracture, which is classified fracture depending upon the relationship of the proximal and distal fragment. Type 1 is undisplaced, non-displaced. Type 2 is deviated. Type 3 is displaced. Either the displacement could be medial and lateral. And type 4 is dislocation. Then Lindahl has also classified condylar fractures based upon three main criteria: the anatomical location of fracture, the relationship of the condylar segment with the mandible, and the relationship of the condylar segment with the glenoid fossa. But for this system, you have to take two radiographs at least right angle to each other. So, and the first thing is the level of condylar fracture: intracapsular fracture, subcondylar fracture, and extracapsular fracture. Then relationship of the condylar segment to the mandibular segment. It could either be non-displaced, deviated, displaced laterally or medially, displaced anteriorly or posteriorly, or no contact between the fractured segment. The other is relationship between the condylar head and the glenoid fossa. Non-displaced, wherein the condylar head is in the normal relationship with the glenoid fossa. Displaced, wherein the condylar head remain within the fossa but there is some alteration in the joint space. Dislocation, wherein the condylar head lies completely outside the confines of the fossa. There is rupture of the capsule. Let's move on to the clinical features of mandibular fractures. Now, on inspection, there will always be an evidence of trauma, either in form of contusion, abrasion, laceration, more specifically in the chin and in the temporomandibular region. On examination, there will be clinical facial asymmetry. Now, this asymmetry can be because of swelling or edema, or it could also be because of the condylar fracture wherein foreshortening of the ramus has occurred, resulting in facial asymmetry. You can also see swelling on the temporomandibular region. Now, this swelling can be because of the hematoma that has collected below the skin, or could be because the segment is displaced laterally, which takes place in very rare condition. Bleeding can also occur from the external auditory canal. Now, on palpation, there will be pain and tenderness. There will be crepitations present because of air entrapped into the soft tissues. There will be restricted translation of the condyle, and crepitation can also be because of the fractured segment trying to move towards over each other. Now, in case the fracture is dislocated, the condyle may not be palpated. Intraorally, there will be a staph deformity will be present, mucosal laceration will be there, sublingual hematoma. It is a classical sign of parasymphysis fractures. Then you could see a midline is deviated, it doesn't coincide, limitation of mandibular movement. Malocclusion will be present. In case of unilateral condylar fracture, there is deviation on opening due to decreased translation of the condyle on the injured side. There will be ipsilateral premature contact of posterior teeth because of foreshortening of the ramus. This will cause contralateral posterior open bite. Where in case of bilateral condylar fracture, there is an anterior open bite and a retrognathic mandible. Now, anterior open bite is because there is posterior teeth will come into contact. There is posterior gagging because of foreshortening, and there will be limitation of mouth movement or mandibular movement. Then we move on to our radiographic investigation. Initially, a mandibular series of radiograph was taken, that is at least two radiographs at 90 degrees to each other, like the lateral oblique view, that is the ramus, mandibular ramus view, Tomes, a reverse view, or OPG. But nowadays, CT scan and 3D reconstruction are the need of the hour. Now, this slide will show you a lateral oblique mandibular ramus view wherein you can appreciate the condylar fracture and vertical ramus fracture. In this OPG shows parasymphysis fracture, and you could see the inferior border, the displacement that you can see here. This slide shows 3D CT reconstruction wherein you could appreciate the bilateral parasymphysis fracture that has taken place. This slide will show you coronal as well as axial section. In coronal section, you could appreciate the fracture of the ramus, and in the axial section, you could appreciate the fracture at the mandibular body region, where is the symphysis region. In the 3D reconstruction, you will get a clear picture that it is not exactly the ramus that is fractured, but a very low subcondylar fracture has taken place along with parasymphysis fracture. Now this CT scan will show you a coronal view of condylar fracture which is displaced medially in both of the CT scans. 3D reconstruction showing ramus fracture, condylar fracture, and you can say a very low subcondylar fracture displaced laterally. Now let's move on to the principle of treatment. Like any other fracture in any other part of the body, similarly we have to treat the mandibular fracture with reduction and immobilization. Okay, now reduction could either be close reduction and immobilization or open reduction and rigid fixation. Now other objective is to control the bleeding and to decrease the infection and maintain the airway. These are three things which are important in mandibular fractures. The definitive treatment is do the debridement, irrigate with saline, give antibiotics, then closure in layers and put a proper dressing. In case of reduction and fixation of soft tissue, you could either opt for close reduction and intermaxillary fixation, open reduction and semi-rigid fixation with intraosseous wires. Gone are the days that we are using wires. Nowadays it's time for mini plates and screws. Then the other treatment modality is open reduction with rigid fixation with bone plates and lag screws. And the most recent one is open reduction with fixation with functional stable fixation, that is with the use of mini plate technique. Now we begin with the conventional approach, that is close reduction technique. Herein simple hand manipulation is done to reduce the fracture. Here the fracture is normally minimally displaced. After reducing it, you will immobilize it either with arch bars or IMF screws or dental wires. Now dental wires could either be direct wires or eyelet wires. Nowadays we prefer more the IMF screws and arch bars, and in few cases we can offer eyelet wiring. The duration of immobilization is in case of maxilla it is 3 to 4 weeks, whereas in case of mandible it is 4 to 6 weeks. This is a case wherein a patient had a fall in the bathroom. You could see the injury on the chin and bleeding from the nose. On intraoral examination, there is presence of a dentoalveolar fracture involving both mandibular central and lateral incisors. The fragment is reduced manually and arch bar is placed. Arch bar is kept. This is the result after 1 month. Now, indication of close reduction. Now, indication in case of non-displaced favorable fracture. Okay, you could offer close reduction. In grossly comminuted fracture. Now, why grossly comminuted fracture? Since in comminuted fracture, the bone is splintered. So when you open it, you will reflect the mucosa. You are stripping off of periosteum. You are depriving the area of the blood supply that it has. So to avoid that, in these cases, we do close reduction. Now fractures in case of children involving the developing dentition, wherein you do not want to injure the dental follicle at that time, you will offer close reduction in case of coronoid fractures. Now contraindication of close reduction. The patient who have poor control seizures, who have epileptic fits attack frequently, these are contraindication. Then the patient with compromised pulmonary function, that is breathing problem, you should avoid it. Patient with psychological or neurological problem, avoid it. Patient those who have eating and GIT disorders, in these cases, close reduction with IMF or arch bar should be avoided. Now the advantage of close reduction is easy, convenient and economical procedure. Short procedure, okay. Give occlusion some leeway space to adjust the discrepancy. No surgery is required. It's an OPD procedure, okay. But the disadvantage is that absolute anatomical reduction is not possible. Absolute stability is not possible. Okay, patient's non-compliance, because when you put IMF, you are asking the patient to go on a liquid diet, and it becomes difficult to keep the oral hygiene clean. So patient compliance play a very important role. So patient, if is non-compliance, then it's a disadvantage. It is disadvantage in case TMJ sequelae can occur. If you have put IMF for a longer time, TMJ problem, decrease in range of motion can occur. Let's move on to the open reduction method. Open reduction could either be intraoral or extraoral. When you're opting for an extraoral, it could either be a Risden's approach or submandibular approach, or a Heinz retromandibular approach. In case of intraoral vestibular incision, you can give a transbuccal incision. It is another case of road traffic accident wherein the patient has a parasymphysis fracture. We try to reduce it manually and put arch bars so that to get a little bit amount of reduction, getting proper occlusion, and then we take the patient into the OT. You will raise the mucoperiosteal flap, give a mucosal incision, raise the complete mucoperiosteal flap, visualize the fracture area. After visualizing the fracture area, reduce the fracture area, get into anatomical position, and then plate it. Now here the debate is there whether you put one plate or two plate. Since we have already put an arch bar on the teeth, it will act like a tension band. So just one plate at the inferior border is sufficient with two screws on either side of the fracture line. This is the occlusion 1 month post-operatively. This is another case wherein there is presence of parasymphysis fracture. Along with parasymphysis fracture, there is low level of condylar fracture. Here also the patient was taken. You already put an arch bar in the beginning. Try to get into occlusion, because occlusion, since the maxilla is intact, when you're treating a mandible, maxillary occlusion act like a guide. How you will know whether the mandible is in correct position or not? You have a certain reference point. So your maxillary occlusion will act like a guide. So you will occlude the maxillary and mandibular teeth, put an IMF. Once you do that, expose the area, see the fracture site, reduce it, and then you put your plates in. Then here, since there was a very low subcondylar fracture, rather than giving submandibular, we have taken a retromandibular approach, expose the area and put plates. When you're treating a condylar fracture, and if sufficient amount of bone is there that you can plate it, you can put two plates at right angle to each other. One plate will be along the sigmoid notch and the other will be at the posterior border. In such a way you will stabilize it. Now, this was about the adult fractures. What about pediatric mandibular fracture? A debate always occurs to opt for conservative or surgical, open reduction or close reduction. In case of pediatric dentoalveolar fracture, close reduction and immobilization with splint is a must for 2 to 3 weeks in case of dentoalveolar fracture. In case of mandibular fracture without displacement, conservative approach, observe liquid diet. You need not treat it. The pediatric population have a better healing property because of their inherent resiliency of the bone, it will heal. So in case of mandibular fractures, body fracture, if it is not displaced, wait and watch. If it is dentoalveolar, because there is always some amount of movement that is taking place, then you need to splint it. In case of mandibular fracture with displacement, you could put a splint and do a circummandibular wiring. In case of displaced symphysis fracture, if the patient is more than 6 years, then you can opt for open reduction internal fixation once the permanent incisors have erupted. In case of parasymphysis fracture, if the patient is above 9 years, then you can do open reduction internal fixation once the canine tooth bud has erupted. And in case of mandibular fractures, if the patient premolar and molar tooth buds are high above, then you can offer open reduction and fixation, rigid fixation. This is another case of pediatric fracture. The age of the patient is around 5 years, wherein you could see there is presence of a pediatric parasymphysis fracture starting from the alveolus to the inferior border. Here the patient was taken up into the OT. Here splint was placed with circummandibular wiring. Now this slide shows how a circummandibular wiring is done. You will mark 2 points extraorally just below the chin in the canine region. Okay, you will insert the bone out from inside the mouth and remove it from outside. Then you pass it through the same hole again inside and get it from the lingual aspect. So you have a splint in between and you have 2 wires projecting, one from buccal, the other from lingual, and then you tighten up the wire and stabilize the spring bilaterally. The entire procedure is done under general anesthesia. Now, let's move on to the condylar fractures. Now, which is divided into two main school of thought. Some believe conservative approach, some believe surgical approach. Now, indication for conservative treatment of condylar fracture. Non-displaced fracture or minimally displaced fracture. Normal or mild occlusal discrepancy with minimal discomfort to the patient. And intracapsular fracture where the condylar fragment is too far from or too short from plating. So basically undisplaced fractures, minimally displaced fracture when occlusion is minimally discrepancy is there and patient can tolerate it, and when there is intracapsular fracture or the head of the condyle is too small to plate. These are the indications. Now the aim of conservative treatment is to provide immobilization for a specific period of time so that bone healing can take place. And its objective is after bone healing takes place, you have to give a lot of physiotherapy so that active movement start. Now, conservative treatment of condylar fracture. When it is not displaced, observe, do not do anything, put the patient on soft diet. When it is displaced slightly, then you will use and the patient can maintain the occlusion, then variable period of immobilization can be done followed by physiotherapy. Now, similarly, immobilization can be done in case of intermaxillary fixation, either by use of arch bars, eyelet wires, splints or intermaxillary fixation screws. Now, the time of immobilization. In the past, as long as 8 weeks of immobilization was done, but currently the protocol has changed. In case of condylar fracture, immobilization for 7 to 21 days is said to be sufficient. Now, this period may be increased or decreased based upon the concomitant factors like the age of the patient, the level of the fracture, the degree of displacement and the presence of adjacent fractures. You could increase or decrease like 3-4 days here and there, but the current scenario states that for condylar fracture, immobilization 7 to 21 days. We should keep in mind that more important than the length of immobilization is the management following immobilization. Early return to function and progressive intensive physiotherapy is a key of success. Okay, it is a crucial aspect of post-immobilization treatment. If you keep the immobilization for a longer time, there are chances of ankylosis happening. There is decreased mandibular movement and we do not want that to happen. Now, Edward Ellis Ford in 2004 has put forward an absolute indication for open reduction of condylar fracture. Means that these are the 4 conditions wherein you have to open the temporomandibular joint and reduce the condyle. And these are displacement of the condyle into the middle cranial fossa, then lateral extracapsular displacement, immobilization to obtain adequate occlusion, because if you cannot obtain the occlusion with conservative approach, then you have to do an open reduction. Then condylar fracture, which is associated with other fractures like Lefort 1 level fractures, then you need to open it up. Now, principle of open reduction of a condylar fracture. Now, once you have opened up the fracture, you have reduced the fracture, how will you plate it? Either to use 1 plate or 2 plate. Okay, when you have sufficient amount of bone on both the side, that is both the distal and the proximal segment, you can use 2 plate. As I mentioned earlier, 1 plate can be at the base of sigmoid notch and the other can be on the posterior border of the mandible. Now, 2 holes on either side of fracture line is sufficient. But if in case the fracture segment is small, that the head of the condyle is small, then 1 thick single plate is sufficient on either side of the fracture line. Now, let's move on to the complication that can arise. Now, complication during the primary treatment could be misapplied fixation, that you have not reduced it properly, you have not fixed it properly. Infection can occur if you have not done a proper antibiotic coverage. Nerve injury can occur. More commonly in the mental region, parasymphysis, mental nerve injury can occur. The teeth may get displaced, foreign body, pulpitis, periodontal problem and drug reaction. The late complications are malunion, delayed union, non-union, derangement of the temporomandibular joint, sequestration of the bone, limitation of opening, and obviously if there is an extraoral scar if you're opting for an extraoral reduction approach. With this, I would like to conclude by saying that numerous investigations have appeared in the literature that has compared conservative to the open reduction internal fixation. There are a lot of advantages of open reduction internal fixation, that is, anatomical reduction of the fracture is possible. Mouth opening and mandibular movement is greater in open reduction internal fixation. Mandibular deviation is less. But at the same time, there are certain advantages of conservative treatment also, that it plays a very important role in pediatric group of patient and in case of treating condylar fracture. So your diagnosis plays a very important role. At the same time, your treatment depends upon the specific need, that is the specific type of fracture. Accordingly, you should offer a conservative and or open reduction to make it more comfortable to the patient both aesthetically and functionally. With this, thank you.